This is an overview on the infective endocarditis topic. In this video, I'm going to review how to diagnose infective endocarditis using the Duke's criteria and also how to treat infective endocarditis. When we talk about the topic of infective endocarditis, you will come across something called Duke's criteria for diagnosis of infective endocarditis. So this is a formal criteria to diagnose patients suspected of having infective endocarditis into either definite, possible, and or rejected, and they diagnose this based on major and minor criteria, whether they're present or not. So major criteria are things like the presence of bacteria in the blood or bacteremia. So this represents as persistent positive blood cultures of microorganisms that are consistent with those of the infective endocarditis. So if we draw blood cultures twice and that are drawn 12 hours apart, and then we find positive cultures for these certain microorganisms, then that means that this is one point towards the major criteria. Second point would be regurgitation murmurs. So if we listen to the heart and we hear these murmur sounds, that is also another point to the major criteria. And these murmurs usually happen if there is vegetation, bacterial growth on the valves, that on the long term can cause defective or can cause the valves not to work as efficient as they should, and then that causes these regurgitation murmurs. Third point would be vegetation. So when the bacteria goes into the bloodstream, lands on the valves, and they start growing and thriving in these areas, then you could see these vegetation through echo. There are two types of techniques that can be used, and the first one is the TTE. This is usually less effective, not as accurate, and then less invasive as well. But then there's the other technique, which is called TEE, which is more invasive, but it is also more accurate. So they usually start with the TTE, and then if there is any suspicion that vegetation is present, then we can go ahead and do the more invasive method, which is the TEE. So moving on to the minor criteria, first point for the minor criteria would be risk factors. So if there's a history of infective endocarditis, if patient is an intravenous drug user, where they inject, the needle, and pathogens from the outside world would stick to the needle and go into the bloodstream that way, from patient's skin, for example. And then if patient also has a prosthetic valve, that could also be a risk factor. Second point would go towards fever that is more than 38 degrees. Third point would be vascular symptoms that are present. So I like to think when vegetations happen on the valves in the heart, the blood flows through the heart, so these vegetations can actually break and flow with the blood. So if the vegetation is on the right side and they break and flow with the blood to the lungs, then this could be in form of pulmonary embolism. But if the vegetation is on the left side, it breaks and flows with the bloodstream, and then if it goes to the brains, then that would be in form of a stroke. And if it goes to other parts of the body, it could be, it could show in other forms, Genway lesions, etc. And then the fourth and the last point would be rheumatological presentation. So again, when the vegetation breaks and flows with the blood, it can cause series of immune response from the body, because it is a foreign body inside, in the blood, and so can cause some manifestations in form of like glomerular nephritis, Osler's node, etc. So with that said, in order for a patient to be diagnosed, we usually see how many major criteria they have versus how many minor criteria they have. So for example, with the definite infective endocarditis, they should present with 2 major criteria from that we've mentioned, and either that or 1 major, 3 minor criteria, or 5 minor criteria. For possible infective endocarditis, they would present with 1 major and 1 minor, or 3 or 4 minor criteria. So I created this slide for what needs to be present for an antibiotic therapy to be ideal and effective for infective endocarditis. So because of how the bacteria grows and causes vegetation on the valves, it does make sense for us to choose an antibiotic that has bactericidal properties rather than bacteriostatic. That way we ensure that the pathogen is completely eradicated, and we ensure complete sterilization of that certain pathogen because of how much the bacteria can tend to thrive and be embedded deep into the valve of the heart. So a bactericidal antibiotic option would be the most optimal. Also, with infective endocarditis, it is usually long-term treatment, so it ranges from 4 to 6 weeks, really depending on the type of valve patient has and a patient case, but it's usually 4 to 6 weeks, so it is a long-term treatment. Also, the majority of infective endocarditis happens from gram-positive pathogens, so strep, staph, and enterococcus are the major pathogens that can cause that disease. And so we think about antibiotics that cover gram-positive and have broad spectrum also to cover the multi-dose, the multi-drug resistant pathogens. So think of methicillin-resistant Staphylococcus aureus or vancomycin-resistant Enterococcus. So we want to think about antibiotics that have a broad spectrum that can be used for empiric therapy. And then finally, you can think about an antibiotic that is on the lower side of volume of distribution. That way we ensure that it stays in the bloodstream and reaches the site of infection to fully eradicate the pathogens and to reach therapeutic levels. Okay, so the last 2 slides on this video I created in hopes to kind of make the empiric therapy treatment of infective endocarditis simpler, because they do tend to get a bit complicated when you go over the 50 pages of the American Heart Association. And so I'm hoping that this can help a bit while studying, and feel free to print out these couple of slides for your reference. So start with the empiric therapy, infective endocarditis with the native valve. The reason why this can get really convoluted is because the empiric therapy really depends on many factors and many aspects. So it depends on the kind of valve the patient has, also depends on the kind of pathogen that we are treating, as well as if there is susceptibility or resistance towards the pathogen, towards the antibiotic that we're using. So it can get really complicated, and so I think it would be easier for us to kind of divide them into subdivisions, if you will. So for the empiric therapy, i.e. with the native valve, if we think about the strep or streptococcus, if it is susceptible, the American Health Association is recommending guidelines of using penicillin or ceftriaxone for 4 weeks, or penicillin or ceftriaxone plus gentamicin for 2 weeks. If it's resistant, we're going to use penicillin plus gentamicin for 4 to 6 weeks. In regards to Staphylococcus, with the native valve infective endocarditis, I want to make sure I put that in red, do not add gentamicin. So the American Heart Association specifically recommends against adding gentamicin in this subgroup. So if it is susceptible, you're just going to use monotherapy nafcillin or oxacillin for 4 to 6 weeks. If resistant, methicillin-resistant Staphylococcus aureus, you're going to use vancomycin monotherapy for 4 to 6 weeks. And finally, with the Enterococcus susceptible, you're going to use penicillin plus gentamicin for 4 to 6 weeks. If resistant, so vancomycin resistant Enterococcus, you can't use vancomycin. So in that case, we're going to use 2 beta-lactams, ampicillin plus high dose of ceftriaxone IV for 6 weeks. Then finally, the empiric therapy, infective endocarditis with prosthetic valve. For Streptococcus susceptible, we're going to use penicillin or ceftriaxone for 6 weeks, or penicillin or ceftriaxone plus gentamicin for 2 weeks. If resistant, we'll use penicillin or ceftriaxone plus gentamicin for 6 weeks. In terms of staph susceptible, we're going to use nafcillin or oxacillin. Here we're going to add rifampin for 6 weeks, and then we can add gentamicin for the first 2 weeks. And then if resistant, we're going to use vancomycin plus rifampin for 6 weeks, and then we can add gentamicin for the first 2 weeks if applicable. And then finally, the Enterococcus susceptible, we do penicillin plus gentamicin for 6 weeks. And if resistant, again, we do the 2 beta-lactams, so ampicillin plus high-dose ceftriaxone for 6 weeks. So note that empiric therapy of native valve infective endocarditis, we could do the lower end of the spectrum with a duration of 4 weeks in some situations, but then with the empiric therapy of infective endocarditis with a prosthetic valve, we do 6 weeks. So we go on the longer side of the spectrum when it comes to the duration of therapy. And then to end this video, just wanted to mention that there is a very small percentage of possibility of getting the infective endocarditis from gram-negative pathogen. So the acronym they use is HASIC, and the drug of choice to treat these certain pathogens would be with ceftriaxone for 4 weeks.